Baylor Scott and White Health Care System, joined with Dr. Ramirez, a neurologist and neurohospitalist at the Baylor University Medical Center, and Dr. Wiley, an internal medicine specialist, and myself, Dr. Roger Caton. We're going to be discussing stroke today, which has been on the tips of our minds with all the commercials about atrial fibrillation, about ischemic stroke, and about the new things that are coming around for stroke for our patients. Dr. Ramirez, to start with, I would just like to ask you a quick question. What are the differences in ischemic stroke that a lot of people hear about and hemorrhagic stroke?
Ischemic stroke is generally, you can think of it as a lack of blood flow to an area of the brain. This can either be due to a blockage of a vessel itself or due to a blood clot that blocks a vessel. The hemorrhagic stroke is usually when you have sometimes an area of ischemia that leaves you with some tissue that it loses its integrity, and it converts by bleeding into that area of tissue that has already had ischemia. Additionally, you can have hemorrhagic stroke when you have a bleed just into the brain. Most of the time, there can be an ischemic component that precedes that.
And when we are referring to a lot of the commercials that our public is seeing, they're hearing about this blood thinner that's to be used in atrial fib. They're referring to an ischemic stroke in that regards, correct?
That's correct. That's correct, because quite often the mechanism there is that there's a blood clot that's flown off from the heart. It travels to one of the vessels in the brain, and it causes a blockage, which leads to lack of blood flow and lack of oxygen, and therefore ischemia.
And Dr. Wiley, in regards to some of your patients that you see in your practice, what are some things you tell them when they're regards to AFib and stroke when they're coming into your office?
Certainly, the number one thing that we want to do is identify as early as possible atrial fibrillation, and we've talked about this in the past, but just to sort of give that definition again, atrial fibrillation is a heart arrhythmia that basically causes the heart to be asynchronous, or not, it doesn't move at the same time or in synchrony as it should. So as a result, blood can pool in the heart, and as the heart is beating irregularly, this can cause some of the blood clots to break off and go up to the brain and block a blood vessel, and causing a stroke. And so what I talk to my patients about is preventing these blood clots. We may not be able to get them out of the atrial fibrillation or the abnormal heart rhythm, but we are hopefully able to decrease their risk of having a stroke by starting one of these blood thinning medications that we have had available over the last 50 years, Coumadin, and then we have new medications that are available that may be a little bit safer. So talking to the patients about being compliant with these medications and doing everything that they can to lower their risk of having a stroke from atrial fibrillation.
I know we all have patients, and we've seen a lot of the public service announcements in regards to stroke quizzes. When should we tell our patients to go to the ER? When should they go to the fire department, etc.? We have patients who go check on their blood pressure. Dr. Ramirez, would you mind giving us some of the information that comes from a stroke quiz, or like if a patient called you, when would you tell them to go to the emergency room?
I think the one that people are most familiar with is the FAST. If you have a facial droop, if your arm is drifting down or appears weak, your speech is off, then the last one is the T, which means time. But I think you have to look for subtle things like even dizziness can present as a sign and symptom of stroke, and it's quite possibly one of the most difficult to pick up on, because people become dizzy and it can be a sign of a posterior circulation stroke, and it's missed because they just kind of think, well, I'm just a little dizzy. So I think one of the things I counsel my patients on is if you have anything like the facial droop, the numbness, weakness on one side of your body, speech changes, or dizziness, or instability of gait, you should probably go straight to the ER or deploy EMS.
And Dr. Wiley, what are some of the things when you see them in your office, particularly in dizziness, because it can be such a varied diagnosis, specifically like vertigo, orthostatic hypotension, meaning your blood pressure falls because of dehydration, or it could be an inner ear issue. How do you help your patients differentiate when it's time to go to the emergency room?
Certainly. You know, definitely questioning them to sort of narrow down, because dizziness can be, it's a very common, you know, complaint that patients have. So, you know, really trying to narrow down, and it, you know, the diagnosis. And if it's not, you know, if they're not on blood pressure medicines, or if their blood pressure is not low, you know, we would check some orthostatic blood pressures in our office. You know, the vertigo, there are certain tests that you can do to determine whether or not they may or may not have vertigo, but it's basically the history. And, you know, acute onset, you know, if any other neurological changes like weakness on one side, or, you know, changes in the speech, that may clue us in that it may be, you know, a stroke symptoms. So, you know, you just kind of have to have that that history intact. It's important to ask the right questions in order to know when to sort of pull the trigger and say, you know what, this is a little bit different than just regular dizziness or regular vertigo. Let's go seek, you know, more a higher, you know, higher medical care. Let's get you over to the ER. So it's really the history, and also, you know, some exam findings that we do in the office. The important thing for our audience to know is when things aren't right, listen to your body, seek medical attention.
Oh, no, I agree with you. One of the things that I think all of us on this panel have discussed is a lot of our patients apologize for coming to our clinic or coming to the ER because of dizziness or hypotension. And we're like, no, you did the right thing. If your body doesn't agree with you, it's okay to come in and we can evaluate you.
Right.
Dr. Ramirez, in regards to the timing, I know that the American Cardiology Association, Neurology Association, and the ACP, American College of Physicians, all endorse a rapid timing in regards to certain medications given for a stroke. Could you go over that with our public about why it's so important to recognize that fast symptoms so that they can get in for timing on medications?
I think the most important part is if you are eligible for any of the new modalities, such as TPA, which is, in lay terms, everybody refers to it as the clot buster, you need to get to the hospital within a 3-hour time frame. We have extended time frames, sometimes to 4.5 hours, and there are certain procedures that can be utilized up to 8 hours. Those are not involving the usual intravenous forms of medications that lyse clots, but they involve more intra-arterial, directly into the blood clot in the brain type modalities. So I think the faster you get there, it gives you the options of one of these modalities become more available to you. And 3-hour window, you really want to get there before that.
And what kind of success have you seen with TPA given in the community, in the environment? Have you seen an improvement in outcomes for patients who presented with a stroke-like symptoms?
Most definitely. You know, the data on that varies tremendously. There are risks involved with administration of medication, but I believe, the data also clearly points out to the fact that the benefits to receiving this therapy in many cases, especially on a clinical basis, clearly outweigh any risks, and those risks can be controlled in the type of setting of a higher level of care. So we definitely see good outcomes. We see people that would have really tragic deficits that recuperate quite well. So very important to get them there in time.
When they're admitted to the hospital, Dr. Wiley and Dr. Ramirez, one of the things I know, we always check their lipid profiles and their diabetic profiles. When they get discharged, what are some of the things, Dr. Wiley, that you look at to see what we can improve from regards to risk factors for our patients who've had strokes?
You make an excellent point, because once you've had a stroke, you're certainly at risk for having another stroke. So our job on the primary care side is to prevent you from having another stroke. And so the things that we look at are certainly cholesterol. We want to make sure we're maximizing your anti-lipid therapy so that we can, because some of the strokes that we've talked about is ischemic stroke, and this can be caused from a cholesterol plaque in the brain that blocks blood flow. So we want to make sure that we, decrease the cholesterol. If our patients smoke, we want to encourage them to discontinue smoking. We want to make sure that we have blood pressure control, because that can also lead to hemorrhagic strokes as well as worsen ischemic strokes, in that if there's a plaque, you have increased blood pressure, it can cause that plaque to break off. So we definitely want to have blood pressure control. If they have diabetes, we want to make sure that we're controlling their diabetes the best we can. We want to encourage them to lose weight, to exercise, just all the things that we can do in order to decrease their risk. And we also want to strongly encourage them to take that antiplatelet therapy that's been prescribed for them in the hospital. And compliance is the most important thing. We like to keep, close tabs on these patients going forward, because some of these things may be changes. I've had many patients that have been referred to me from the hospital that have never, had any real or major medical problems, and then, all of a sudden they have to take all these medications. So really stressing to these patients the importance of compliance with their medications.
And Dr. Ramirez, Dr. Wiley referred to like antiplatelet medications, and I know for some of our lay population, they understand the aspirin or the urgency of an aspirin, and the other medications sometimes are clopidogrel or Plavix or Agrinox, which is a combination. Could you specify the differences in regards to these antiplatelet medications and why they're so important in the use of ischemic stroke?
Usually when somebody has not ever been on aspirin, we treat people that have had stroke-like symptoms with aspirin initially. If they present with a stroke and they are already on aspirin therapy, then I hate to say the word, but it's really, they're considered an aspirin failure. Therefore, you move on to these other modalities. The Plavix is an antiplatelet agent. What it does is it prevents your platelets, which are the blood elements that cause your blood to be thickened to form a clot, from being as sticky. And therefore, we use this to prevent clot formation. Agrinox has a similar effect. The important thing is with Plavix, one of the things that if you are a patient that I would want you to take away from this talk is I want you to ask your doctor about testing for Plavix resistance, because 30% of the population that comes out of the hospital gets put on Plavix either for a cardiac event or for stroke. They're resistant to the use of Plavix. Either they don't convert the drug from its inactive form to its active form, or it doesn't have the appropriate action on the platelets that it needs to have. So both those medications really act to inhibit platelets from aggregating together into a clot. Aspirin has similar effects. The differences between them is we usually have to switch from one to the other depending upon if you've had recurrent stroke and you have not done so well on another agent. Either you failed aspirin or you've been on Plavix, or you're resistant to Plavix, and we have to switch you to something like Agrinox.
Dr. Ramirez, Dr. Wiley and I sometimes get patients who come in here and talk about having mini strokes, and then they still have the deficits, and it's lasting for long periods of time. Could you help our public know the difference between a TIA, or a transient ischemic attack, versus a cerebral vascular accident or true stroke?
Yes. Stroke is a continuum. A TIA is really a warning of a stroke, and the difference that you have to keep in mind is with a transient ischemic event, or transient ischemic attack, which is what TIA stands for, it is a reversible event. There's usually not damage left on the MRI or the CT. If you have a stroke, your symptoms will last longer, your deficits will be more permanent, and you will see the evidence of that insult on an imaging study like an MRI or CT. So it basically boils down to the TIA being reversible, and you shouldn't have symptoms for a prolonged period of time. And these can vary from 24 hours, we used to say sometimes up to a week, but you should not have it longer than a few days, for sure. Then you'd start getting into the territory of it being a cerebrovascular accident, and likely there is evidence of that on an imaging study.
Thank you. And one of the things I want to just make sure of that people on our viewing population understand is the importance of going to a hospital with a stroke accreditation. And I know that you all are neurohospitalists in the hospital with our interventional radiologists, our neurosurgeons, and we have emergent CT available, so that the timing is once someone says stroke, that we get them an emergent CT immediately to make sure they don't have any bleeding and that they can have these interventions. I think we're pretty lucky, wouldn't you all agree, with Baylor Scott White that we have several hospitals in our system who are stroke accredited. Is that correct, Dr. Ramirez?
Correct.
And Dr. Wiley, do you have any closing comments for those patients who are coming to you with a TIA or a stroke today?
Well, you know, the most important thing is, like we've stated, is if you have any of these symptoms, definitely seek medical attention quickly. If you've been diagnosed with having a stroke or a TIA in the past, make sure you stay compliant with your medication so that we can prevent further strokes or TIAs. And then I want to highlight a great point that you made. It's, you know, it's said in the literature that patients who are treated in a multidisciplinary stroke unit actually do better. So here at Baylor, we do have that. So, you know, if you do and if you can get to Baylor, of course you want to, you know, go to the place that's closest to you. But being in a hospital where there's a multidisciplinary team approach to treating stroke, patients are likely to do better. Thank you.
And Dr. Ramirez, any closing words as one of our neurohospitalists in that multidisciplinary team?
I think I would echo exactly what was said. I think that being educated about the symptoms and really not taking for granted if your body doesn't feel right, it's best to just don't have any concern about whether, you know, you think you're overreacting or not. It's better to be on the safe side so that we can get you to a place where we can intervene rapidly and aggressively and make sure that your outcomes are the best. And one of these multidisciplinary centers like Baylor is definitely the place you want to be because it can address the stroke not only from the level of the medical care but also rehabilitation and other modalities that get you back to high functioning status if you do have a catastrophic event.
Well, you both have been so educational to me that I feel like at least if I got dizzy, because Dr. Wiley saw me next door, that she would at least be able to educate me to tell me, hey, it's important to go in. For the population out there, we appreciate you watching our Google Hangout with Baylor Scott and White Healthcare System with Dr. Ramirez, Dr. Wiley, and myself, Dr. Caton. Y'all have a good day, and thank you all for joining us on the Google Hangout.
Thank you.
Thank you.